Brainpreneurs Child Development Center. We are a team of different specialists and therapists working together for children with special needs. Our team consists of doctors, clinical psychologists, child and adolescent psychologists, special educators, speech therapists, occupational therapists, and many more. On behalf of Brainpreneurs Child Development Center, I welcome you all in this webinar on the theme, Same World, Different Perspective, Understanding Autism. First of all, I'd like to thank our panelists for joining us today. Our chairperson is Dr. Sushil Razdan. He is a renowned neurologist with over 45 years of experience. Our panelists include Dr. Jagdish Thapa. He is specialized in neuropsychiatry and de-addiction. Dr. Mir Zafar Iqbal. He is the director of Composite Regional Center, Ministry of Social Justice and Empowerment, Government of India. He has an experience of 18 years in the field of disability rehabilitation. Dr. Garima, she is MD in pediatrics, practicing in Safdarjung Hospital, Delhi. Ms. Aprajita, she is child and adolescent psychologist, and Ms. Shambhavi, clinical psychologist and psychotherapist. In the recent years, we have seen an increase in the number of children diagnosed with autism spectrum disorder. To be precise, around 1 in 59 in US. There is a saying that if you know one person with autism, then you know one person with autism. That is how varied autism is. Each child is different and has to be taken care of accordingly. However, there are certain common features that are found in children with autism spectrum disorder. These include repetitive behavior pattern, poor eye contact, and lack of social interaction. But before moving forward with our panel discussion, I would like to share a small incident from my first day of college. Well, we were asked to make a poster on what we want to do in our research thesis. That day, I made in my poster, I listed that I wanted to develop an alternate way of communication for children with autism, something similar to what we have, such as Braille or sign language for those with physical disabilities. However, little did I know at that time that how ambitious my target was, but probably by bringing great minds together, we can achieve it someday. On this note, I would like to begin our discussion with Ms. Shambhavi. So, Shambhavi ma'am, I would like to first ask you that can you explain that why autism is considered to be a spectrum disorder and what can be other associated conditions in the child with along with autism?
Thank you, Sanika, and thank you, Brainpreneurs and Child Development Center, for giving me an opportunity to share this platform here. So coming to your question that why do we consider autism as a spectrum disorder? So as you rightly said in the beginning that if you meet one person with autism, you meet one person with autism. So different people with autism might have different symptoms, and it is very hard to put in a rigid nomenclature when it comes to the diagnosis. So initially when DSM was introduced, it included multiple diagnoses with autism. And those were pervasive developmental disorder, not otherwise specified, Asperger's disorder. It was childhood disintegrated disorder. So when they updated the DSM-5, they included all these disorders under one umbrella term, which they named as autism spectrum. So when they speak about spectrum, they just combine social communication and impairment into one criteria. Also, a spectrum allows the clinicians to make diagnosis. Also, it gives justice to diversity that individuals have with different symptoms with autism. So when we talk about these spectrum symptoms, it could be in terms of executive functioning, information processing, motor skills, or perseverative thinking, and there are a lot of other symptoms. So many people say this that, if a child has, good eye contact or no eye contact, that's the important diagnostic factor. And yes, definitely it is applicable to most of the cases, but not all the cases. So some people might have a very good eye contact, but they might lack in other skills like communication or, there could be perseverative thinking. So that's why the word spectrum has been introduced, to make justice to individual differences who have autism spectrum or who suffer through autism spectrum disorder. Also, there was another question that what are the other conditions that are comorbid with autism? So, children with autism go through a lot of comorbid conditions, and one of those could be a lot of feeding or eating issues. So, 7 out of 10 children with autism have extremely restricted food habits and aversions to taste and textures. Children on autism could have pica, which is eating non edible items. Children with autism can have disturbances with sleep. So they have chronic sleep problems, which can manifest as a lot of behavioral challenges later on. Also, children with autism could also have attention deficit hyperactivity disorder, where they might have difficulty to pay attention or sit at one place for a long time or for sufficient time, that could be 30 to 45 minutes when a teaching session takes place. So yeah, 30 to 60% of children do suffer from ADHD. So I was talking, these symptoms were related to children. So as we grow older, there could be symptoms like anxiety, because these people have a lot of issues when it comes to expression. So there could be a lot of social anxiety or fear of crowds, new situations. So 3% of children and 15% of adults, suffer from anxiety. There is depression. 7% of children and 26% of adults do suffer from depression, because there are a lot of communication challenges that these children have to face in later life. Also, it is very rare, but children or adults can also go through schizophrenia, which is highly comorbid with autism, where there is processing language and difficulty in understanding thoughts and feelings. Processing language disorder is also seen. So yes, the psychosis and hallucinations can be figured out in later part, because it's very difficult to diagnose schizophrenia in children, because they overlap with symptoms of autism.
Right.
So yes, so there are a lot of comorbidities that children can go through while having been diagnosed with autism spectrum.
Right. So you've pointed out quite a number of associated conditions. So at what time do you think to just make it easy for parents to pick up the signs and start early intervention as soon as possible? What suggestions or what do you think should parents do? Should we, without being very anxious, like how can we pick up signs so that we are not over worried and not over critical about each and everything, that my child is falling down again and again, so is it something wrong with him? So not keeping that, but there are certain signs that I think we can suggest parents to pick,
Right.
so that we can start early intervention. What do you think? What suggestions do you have on that?
Right. So to pick up on red flags for parents, it's very important to check on the developmental milestones chart that a child goes through. Also, children with autism they have issue with communication or maintaining eye contact. So if your child is not looking at you, not smiling at you, not reciprocating back, then these could be a minor red flags which parents can pick up at a very young age. Also, name calling. If you're calling the child by its name and the child is not responding or is not coming, then that could be another red flag, that why is the child not responding to the name.
Right.
So these are early red flags that parents could pick up at initial
Right.
phases.
Also, Shambhavi, can you also make a little clarity about that, how developmental delay and say intellectual disability could be very different from autism? Because sometimes it is probably, if speech is not developed properly, we may assume that it is autism, or whether the child is just behind a milestone. So is there a clear criteria how we can differentiate that?
Right. So a lot of times symptoms might overlap when we talk about early phases or early developmental phase of a child, but later on you can pick up on certain symptoms which I'll talk about. So let's first understand what is intellectual disability and what is autism spectrum. Intellectual disability usually is, has its early onset during the developmental period of the child. It includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. So deficits in IQ could be difficulty in reasoning, problem solving, abstract thinking, planning, also which has to be confirmed by a clinical assessment and a standardized test. So you can't just say and see and say that, okay, the child might not have abstract thinking, but it has to be verified by a clinical assessment and a standardized test. When I talk about adaptive functioning of a child, I say that the child might fail to meet developmental and social cultural standards for personal independence and social responsibility. So the child might require help in basic things, and he might not be able to meet the social responsibility. And he might need help in personal development, like adaptive functionings, like going to the washroom, or putting up his shoelaces, anything. These adaptive skills might require help. When we talk about autism spectrum, as you rightly said, there are persistent deficits in social communication and interaction. A reciprocal interaction is not there. And also, there is restricted and repetitive patterns of behavior, interest, and activities. So, when we start building skills in children with intellectual disability and autism, the skill building in children with intellectual disability is at a pretty uniform pace. So, if there is a developmental delay, there will be a delay in all aspects: social, cognition, physical, everything. That doesn't happen in autism. So, if a child is very good in the physical aspect or cognition, the child might lack in communication. Also, when you start training the child will pick up on certain skills very fast with autism. Like fine motor, gross motor skills will be learned very fast, but then social communication might come later. The child might take a lot of time to learn basic pragmatics of communication or language. That doesn't happen with children with intellectual disabilities. They pick up on certain skills at a steady pace. Right. So this is where you differentiate between autism and intellectual disability. Coming to your global developmental delay part, global developmental delay is diagnosed with children 5 years and before that, when a standardized clinical test could not be applied and the child fails to meet developmental milestones that normal children of his or her age might attain. So that's where we go to the global developmental delay part of it.
Great. I think you have explained a lot of things pretty clearly. And since Shambhavi has very well told us a lot about the behavioral aspect of autism and what we see or observe from outside, I think it would be a good idea to also see that what is there in the brain. And since everything in our body is guided by the brain and the way our neurons interact and different parts of the brain are functioning, let's see and try to understand that is there some major differences in brain development as well, so which probably could be a reason that why we see such varied behavioral manifestations in the children. So Ms. Aprajita, if you could shed some light on that, that if are there any major brain development differences as well in case of children with autism and those who are typically developing?
Yes, of course, Tanika. If you go by the neuroscience researchers, a lot of researchers have now shown that a lot of be it the region, be it the connectivity, the wiring in the brain, or the connections, the neurotransmitters, all of this play a major role. And this actually differentiates a non-autistic child from an autistic child. So I will be starting with the size of the brain. So when the child is born to 2 years of age, the brain actually grows very fast. There's an overgrowth of brain than a normal child, and after 2 3 years of age, this growth actually starts declining at a very accelerated rate. So this is one of the differences that neuroscience is now observing. Secondly, like I said, there's a lot of difference in the many regions of the brain. There's a lot of abnormality has been observed in the regions of the brain. I'll give an example of amygdala. So amygdala volume also grows in the autistic child, and because of which a lot of behavioral issues have been observed in the autistic kids. Now, talking about the connection, now there's also a failure to develop normal connections between temporal, parietal, and occipital lobe in the autistic kids. And because of this, again, a lot of abnormality has been observed in autism. Now, I would also put some light on the neurotransmitters. Now, emerging evidence has also shown abnormalities in the excitatory and inhibitory neurotransmitters such as glutamate and GABA. So because of which, because of the abnormality in the neurotransmitters, a lot of increase in the impulsivity of the child with autism, this has also been observed. So since Sanika, when you talk about ADHD is a disorder of hyperactivity. So the it is very easy for a pediatrician or any doctor to give the medication, but because of these differences and in different so many parts of the brain, it for the doctor it becomes very difficult as to what medication should be supplied or what medication should be given. So I think it is very important now that we start working towards neuroscience and more of such researches are done so that we can actually figure out that, for example, if there's impulsivity in the child, that proper symptom is able to be targeted, and then a proper medication for that is given. So yes, a lot of differences has been seen apart from the ones I have just mentioned.
Right. So I think since we have a renowned neurologist with us today, I would also like Dr. Razdan to give his opinion, because a difference in brain and such limitation, how do we work with that? Because ultimately what we want is child to develop or, have a proper growth, be independent. So, sir, with such a limitation in brain, that how is that possible? What are your opinions? How can we work with such limitation?
Good afternoon, everybody. It's nice to be with you, Sanika, and others. I'll not take more time now in saying hello to everybody. The point is the disorder of autism spectrum disorder is in brain. It's so simple. But conventional imaging and investigations have shown it to be normal. If you do a CT scan in an autistic child, or you do an MRI, even 3 Tesla MRI, you hardly find any structural abnormalities. But a couple of things are very important. At microscopic levels, they have found changes in dendrites, synaptic connections, and I think with passage of times and with the help of AI, artificial intelligence, where a lot of data will be collected, you will find some changes in connectome, the connective, the circuits will show some changes. And fMRI also shows some changes in them, but they are not very categoric and definite as yet. It's very important. At a gross imaging levels, if you do an EEG, if you do MRI, if you do CT, you hardly find any changes in these. But they still are done. These tests are still done. We still do an MRI. We do. It's not very mandatory to rule out some conditions like Rett syndrome, tuberous sclerosis, or neurometabolic, which could mimic autistic spectrum disorder. We'll come to that later. How can we do that? But one thing which has happened again is the genetics have come up fast. And again, the only way this has helped is by AI, artificial intelligence. Now, some years back, we thought that there'd be 30, 40 gene abnormalities, but with the advent of AI, thousands of loci have been found to be in autistic children to be of significance or unknown significance. They have found it. And next 2-3 years, I'm sure we'll be very much wiser about these things. But the only problem is many of the abnormalities are found, similar abnormalities are found in other childhood development like ADHD or other disorders where the development delay is there. The point is we are working, learning fast about the synaptic biochemical and genetic abnormalities. And I'm sure in next 2-3 years we'll be much wiser and better off.
I think technology is the way ahead, and with the
Way ahead. That can give us that.
That can give us
Thank you.
better. Thank you so much sir, for your opinion. Now coming back to you, Prajita. There's another thing which we've observed about the assessment pattern, because since most of the assessments and psychological tests are done by clinicians, clinical psychologists, and they divide children, or they give a diagnosis on a rating scale of, say, level 1, level 2, and level 3, which was earlier mild, moderate, and severe. So can you also explain that what does these scores mean, and do you think is there a better way or a better assessment that can be developed, say, in future? Maybe after immense research and all, but right now we are more dependent upon a self-rating measures or parental rating measures. Sorry, not self-rating, but parental rating measures. So can there be a better way to assess?
Okay. So Sanika, while making the diagnosis and when we have to reach to whether it is a level 1, level 2, or level 3, first thing that we also have to keep in mind, according to DSM, is the intellectual profile of the child. And that is very important to keep that in mind. And then now I would like to explain you what is the meaning of level 1, level 2, and level 3. Now when I talk about level 1 means that it is a mild level which requires support. Now here there are problems in social situations, there are problems in stereotypical behavior, repetitive behavior. However, the child will be able to communicate his needs and perform his day-to-day activities. But the problem here will be when the child has to take turn in the conversation, when the child has to take turn in the activities, or when they have to switch their roles in an activity, there where the problem lies. Another thing where the problem lies is planning and organizing. So children who fall within level 1, they go through these issues. Now talking about level 2, which is requiring substantial support. Now here there are marked deficits in verbal and non-verbal social communication. They speak simple sentences. However, their interaction is limited. So for example, the child will be more interactive with the person he knows. So maybe he'll be more interactive within the family and less interactive with the people around him. For example, he goes out and there he will have difficulty in maintaining eye contact or being open with them or having a proper communication with them. Then they will also have difficulty coping with the change. So we all know that autistic kids are more comfortable with the daily routine and the daily patterns, and if there's a disruption, they are very uncomfortable and it is very stressful for them. So these kids, they actually become very distressed by a change caused in their routine. Now, talking about level 3, which is equivalent to a severe level and which requires very substantial support. Now, this substantial support is required in their communication. It is required in their day-to-day activities. It is again required when, more intervention is required when it comes to their repetitive, stereotypical behavior. Now, there are severe deficits in verbal and non-verbal communication, which cause severe impairment in their functioning. And they can only speak few words of intelligible speech. They rarely interact, and for example, if they have to, present their need to someone, they would probably just use one word for it. So the vocabulary is very low over here. Second, they respond to only direct social approaches. So there's also an issue with the response rate here. So yeah, Sanika, this was all about the severity levels that you asked me. And now coming to your next question, which was about assessments. Now the
Yes.
assessments which psychologists use, They are standardized tests. So in India, most of the psychologists use ESA, and also their cards is also being applied in India. So they all are standardized tests, and also before coming down to the assessment, the psychologist will make sure to have an observation with the child, his own observation. He will not directly go to the parent and ask for the questions. A self observation by the psychologist is also made, which is very mandatory. Apart from the psychological test, of course a lot can be done, and this, like I said, we need to explore neuroscience now. More of MRIs is to be done, like Dr. Razan also mentioned. More such things need to be done. More we have to explore more on this side, so that, apart from psychological test, we also have something which is based on the organicity, that cause, why it is happening, and to be able to target that particular symptom, you know so I think if we have more of those researches going on, and more of those researches can definitely help the psychologist and the doctors to actually have a planned intervention for the child.
Right. I think research is the way ahead because
Yes.
for a long, long time, autism has been there, been existing there, but as common it is, the knowledge about it is very uncommon even today. So
Yes.
only those who are working in the area, or probably who are having a child with autism, are well aware about what this condition is. But in general knowledge, we still have a little less awareness.
And Sanika, I think everybody, now not just the doctors, I think everyone needs to have more awareness around it when it comes to the symptoms, when it comes to the what region, what part of the brain. Like it's Dr. Razan also mentioned, it's a disorder of the brain. So people need to start more educating themselves about the brain. Be it a psychologist, be it anyone. Everyone needs to have more awareness around it.
Right. I think thank you so much, Aprajita. And now, since Aprajita has mentioned so much about Dr. Razdan, I would like to come to Dr. Razdan. And one thing, sir, which we have seen, as well as even Shambhavi mentioned earlier, that there are a lot of associated conditions with child with autism. So sometimes our experience have shown that in case of seizure, the learning relapses after each seizure episode. And in this situation, it gets very difficult for educators to teach anything to the child or train the child and progress. It becomes very difficult. So, in such cases, how can we have a proper intervention criteria, and how to best handle such cases?
Thank you, Sanika. Uh, these, you see, when you have autistic disorders, you're right. The core symptom is social communication, social behavior, repetitive behavior. This is the core symptom, but it is not as categoric and as tight as we teach or as we define. There's a wide phenotypic spectrum. They can, as you rightly said, as Shamvi said, they can have attention deficit, they can have seizures, they can have cognitive disturbances, they can have anxiety, they can have language disorder. So many, it's a huge, it becomes very, very wide and wide as you go on seeing more and more patients, more and more children. I wouldn't call them patients. The point is, they can have seizures associated with them, definitely. Its exactness is not yet known how many, but a good number can have comorbidity of epilepsy. When you have seizures with a child like autism, you should be very careful in making a problem. This is a child where you should go for imaging, where you should go for EEG, where you should go for metabolic profile. It's very important to do a neurometabolic profile. Very important. These are huge number of micro abnormalities which could be in enzymes, which could be in urea cycle disorders, which could be in amino acid disorders, organic acid. For example, I give you phenylketonuria is a neurometabolic. They can have many features like autistic child. Many features. It's very important, and you can have drugs for that, and you can have dietary treatment for that. And now the second part of the question is, do seizures? See, whenever you get repeated seizures, they cause cognitive disturbances, especially in children. They even cause speech disturbances. There is one disease, not autistic, which can be sometimes mimicked like autistic, that's known as Landau-Kleffner disease. They get, after 3, 4, 5 years of age, repeated seizures and they lose speech. Totally, they babble and they lose speech. The point is, seizures, relentless seizures are very important to be controlled. Otherwise, whole cognitive profile can change, and then the whole thing, the parents will be always preoccupied with seizure control, and that has to be a must. Then only your all therapies will go on. Otherwise, it will be risky to give therapies to them, because they may get a seizure in the clinic, in your center, which will cause a lot of issues there. You will not have proper way to control them. It causes a lot of distress to the therapist as well as to the caregivers, parents there. My point is, seizures are very important to be controlled. And in addition, one should look for a cause which could be common to both. That was my point. Common to both. If there's a seizure, I think it is a red flag in diagnosis. Make a proper assessment. Make a proper revisit the patient as a whole. Revisit the patient.
I think picking from that point, it's also important to understand that in cases where we have a little inconsistency between medical and psychological assessment, what can we do then? Because our psychological assessment are based on very different criteria, and medical diagnosis is very different. They're from, one is psychology, one is medicine. So in case of inconsistency, how can we best manage such situations?
I think you should give time to your psychologist, to your doctors. Over a period of time, the diagnosis will come through. I think it could be not a diagnosis in one sitting. In fact, the child should be observed in the clinic, in therapy centers, even at home, I think. Even at home. It cannot be one-off. It's very, very, it can be, see, they can have a lot of issues in one session or two. So they have to be looked at a proper, and then there are a lot of overlaps. That's what my point is. These ADHD, autism, etc., are not rigid as we teach and as we make a diagnosis, as they are taught in textbooks. They have a lot of overlap, and they have a very wide spectrum. In fact, from mild to moderate to severe. That would be one. Other thing is associations, comorbidities. And that's why I call them, there's a neurodiversity. They are not neurotypical. They are neurodiverse children who could, 2/3 or half of them could live even normally if you make changes in their environment, rather than label all of them abnormal. They are neurodiverse. They are not neurotypical. And unfortunately, we people in this planet want neurotypical. Everybody should be good in maths, good in bio, good in drawing, good in conversation, good in sleep, good in play. It's not possible. It is not evolutionary possible. That's why we have a lot of issues in schools, in colleges. I'm going a little away from the main thing. My point is, we have to accept neurodiversity and change our schools, homes, parents, and society, so that these children are accepted as part of neurodiversity rather than abnormality. And then it becomes easier to. Otherwise, stigma hota hai, shame hoti hai. The parents don't take them to parties. The parents don't take them for seeing a movie. They all feel embarrassed. That should not be. I think I give it back to you, Sanika.
That's a very, very good point, sir. I think which you have picked, that how we need to change the idea of what neurotypical or what normal is. The use of term, I think normal needs to go under microscope before anything else, so that we can have more acceptance in the society. Thank you, sir. That was a very insightful point that you've just given us. Now, from here, I think we got a little details about the differences about psychological as well as a medical perspective. So Dr. Garima is here with us. She's a pediatrician. And so I think we can go to her now to get a little clarification about the need of medication in case of children with autism. So how do we decide whether we need medicines or not? Because certain conditions like behavioral aspects, they can be taken care through intervention and psychological areas. But
Right.
when do we clearly say that, there is a need for medication for the child as well?
So firstly, a very good evening to everybody who's joined us today, and thank you for inviting me here. So as you said that, knowing one child with autism is basically knowing one child with autism. Every treatment is very, very individualized. And I would just like to add one point to what Razdan sir had said about these various syndromes that exist as well, that are very common mimics of autism. So in pediatrics, we actually call them syndromic autism. So, these syndromes like Rett syndrome, Angelman syndrome, Down syndrome, Charge syndrome, there is another syndrome called Timothy syndrome and Joubert syndrome. These actually form 20% of the lot of autism. So actually, these are termed as organic autism spectrum. So as you said, now we move on to the pharmacological aspect of it. And let us firstly know that we have to be very realistic with what we expect out of therapy as well as medicines. And there is no medication that actually targets the core symptoms of ASD per se. So the core symptoms are not taken care of by pharmacology. What is taken care of by pharmacology is all the concurrent symptoms that exist along with autism spectrum. So I'd like to shed some light on the very common ones that we see. So the very first one that I'd like to talk about is epilepsy. Now, epilepsy is seen in 35% of kids with autism, which is quite a great number. So a lot of these kids actually do need anti-epileptics. And as you were talking about, epilepsy is one of the major concurrent conditions that exists. The next thing that does exist is hyperactivity and inattention, as mentioned by Shambhavi and Aprajita. There are three classes of drugs that we can actually use to target hyperactivity or inattention, which actually amounts to around 44% of comorbidity in autistic children. So we have these three classes of drugs. We can either use stimulants like methylphenidate. We use alpha-2 agonists like clonidine, and then we have selective norepinephrine uptake inhibitors like atomoxetine, etc. So these drugs can be used to deal with a hyperactivity or an inattention kind of a profile. The next very common comorbidity that we see is, as mentioned by everybody else, is anxiety, which is seen in around 40% of children. So we do use SSRIs like escitalopram, like fluoxetine, and all of this is kind of dependent upon the clinician's prerogative, right? Depending on the patient profile. So for anxiety, we prefer SSRIs. For anxiety that is very situational, sometimes benzodiazepines can also be prescribed. Now, the third concurrent condition that we like to speak about, which is very common, is irritability, aggressive behaviors, self-injury, and these might constitute up to 68% of children actually suffer with these. And it comes from a variety of factors: children not being able to communicate well, being very hyperreactive to their surroundings, and being very, very irritable. So, there is this spectrum of kids also, we need to deal with. And for them, again, we give these two drugs that are actually given are risperidone and aripiprazole, which are actually atypical antipsychotics. And secondly, these drugs have also found to be useful in dealing with repetitive behaviors. So the benefits of these drugs are basically twofold. One is taking care of the aggressive self-injurious behavior. And secondly, also trying to attenuate the repetitive behaviors that are present in these kids. The fifth symptom that I would like to talk about is insomnia. And a lot of parents will come to you there are two kinds of issues that might happen. They might say that the child is not getting to sleep, like we are having trouble putting the child to sleep, or if the child is sleeping, the child is having night waking episodes, right? So these are two issues that are there in these children. So there are drugs like melatonin that can be given that can actually initiate the sleep for this child, but it doesn't take care of the night waking that well. So for the night waking part, we have drugs like clonidine, that are probably better in maintaining that sleep. And I think the last thing that is also concurrently present is, as everybody mentioned, our mood disorders. So we prescribe a lot of these anti-epileptics that have additional mood stabilizing features like valproate, right? So these also can be tapered and used in kids. And just a little word on a lot of these experimental treatments that are also coming out. So we have a few studies that are going on about intranasal oxytocin. So we found out that in a lot of autistic children, if you do a pre-test, there are low oxytocin levels, and a lot of these kids have benefited with intranasal peptide oxytocin with regards to their social functioning. So these are certain experimental treatments, drugs that we might be seeing in the future. But as of now, these are the various gambit of drugs that we use. You have to remember that these are to be monitored very nicely. The kid needs to be monitored. The drug needs to be tapered with regards to side effects, etc. So you need to be on a long-term follow-up with your pediatrician. It's not like you begin these drugs and then you can just disappear. So I think a constant follow-up and monitoring of the adverse effects is very important. So I hope I was able to answer a little bit of that.
Yes, I think Dr. Garima, you gave us a lot of information, which is more than I have read throughout my life. So thanks a lot for that. Yeah. And I think I would also like Dr. Thapa here to add a comment on this. He's a renowned psychiatrist. And so we would also like to know that what can be the possible best intervention and treatment practices for children with autism? How do we work together on this? Dr. Thapa, you have to unmute yourself. You're on mute.
Okay.
Yes, sir.
Okay. Now I am audible?
Yes, sir.
Good afternoon. Today topic is you have chosen a very nice topic because the prevalence rate of autism is going very high. If we talk of India, 0.5 to 1% people, mean 10 million of children are suffering from autism. So it's very high. And maybe there are two factors I consider. The one is more awareness among the people. And the second, maybe a prevalence rate is going high because of some neurological or psychological changes are there. If we talk of the treatment part, the educational and behavior interventions, they are considered to the best treatment in this. Educational behavior. So there are goal of treatment. What are the basically goal? These people are socially and language, communication, behavior. These four areas are very disturbed. Their social skills are disturbed, right? They cannot communicate properly. Their language is disturbed, and they have a behavior oddities like mannerism, stereotypy. They have sometimes temper tantrum. Yeah? So many other things, behavior abnormalities are seen in these children. So the aim should be increase their social acceptability and pro-social behavior, the number one. The second aim should be we have to decrease their odd behavior symptoms. And the third is we have to improve their verbal and non-verbal communication. These are the three, I think, are goal of the treatment. There are various treatments. Everybody has discussed this. I don't want to discuss again and again, but ABA, mean applied behavior analysis, is number one. Then occupational therapy, we have discussed speech therapy, physical therapy, pharmacological therapy, just discussed before you. And we can do some counseling, and the counseling for not for the child. I think the parents has to give more time. Parent had be counseled. I will tell simple thing that government of India has made 2-3 things. One card is there. That card is known as mother-child protection card. It means mother has to be educated. I think psychoeducation to the mother. There are, I was saying that 3, 6, 9, 12 month mother has to be kept in mind while observing the child. At the age of 3 months, there should be a social smile on the face of the child, which is a very important initially. At the age of 6 months, okay, can I carry on?
Yes, sir, please.
At the age of 3
Please,
months,
please.
okay. At the age of 3 months, social smile is very important. And at the age of 6, just not very that, just tell to the mother, this you have to observe. 6 months, the child should sit. And the 9 months, he should stand with the sport and take 1 to step. And 12 months, he should walk and he should say some word. So these 3, 6, 9, 12, these things, we have to tell the mother that this has to be considered. Now, pharmacologically, as discussed, what we do pharmacologically, we have to control aggression, severe temper tantrum, self-injurious behavior in these children, hyperactivity, and most is obsessive. They have an obsessive type of a nature. You cannot change they want to be sameness of the thing. You cannot change their thing. And mannerism and stereotypes are all there. Man, we have tried in some people haloperidol, but it causes neuroleptic syndrome and tardive dyskinesia. Then risperidone, very good drug, already said, but dose is 0.5 milligram to 4 milligram per day. And this drug is FDA approved, only this drug. The other olanzapine has been tried. I'm audible. Can you hear me?
Yes, sir. You're
Okay. And the other is quetiapine, clozapine, diprasidone. There are so many drugs. And even in some cases where the OC symptoms are more, we can try SSRI.
right.
So that is the point is the early diagnosis give the better result. And as already classified, we see mild, moderate, and severe type of things. 70% of these people, they have low IQ, and 30% have, as rightly said, is they have a seizure disorder, and other comorbidity as well, ADHD and other things, they have been taken care of. And one thing I want to tell again, we have to differentiate what is the temper tantrum and what is the meltdown syndrome. Temper tantrum and meltdown, right? Temper tantrum, because of the non-communication, child start crying, throwing himself on the floor, start screaming, start crying. When you give that thing, he will be quiet. This is temper tantrum. Whereas it is not a meltdown. Meltdown, the child is not know what he wants. So that meltdown syndrome lies longer as compared to temper tantrum. And the one word they use, scared. That patient, the child, we have to make him safe, calm, affirmative. His routine has to be maintained, empathetic treatment should be given to the child to make him calm down in meltdown syndrome. That's all.
Right. Thank you. Thank you so much, sir. I think this was a very interesting point that you
Thank you.
said about tantrum and about meltdown. I think, Shambhavi, would you like to add something to this? Because I think that we do see cases there as in our organization as well, where plus even for parents, it's very difficult to differentiate between the two. So.
Right, right, Sanika. So as Dr. Thapa rightly said, that it is very crucial to differentiate between an autistic meltdown and a temper tantrum. Also by the special educators and the parents and whoever is training the child, because these symptoms overlap. And as Dr. Thapa sir rightly pointed out, that whenever there is a temper tantrum, there's a motive behind the tantrum. So if you give that to the child will calm down. And whenever there is a meltdown, it is because of the sensory overload that the child has, which the child is not able to express. So it could be tactile issues, or it could be any loud noise, or it could be oral sensory issue that the child is not able to express properly. So here, a best way to kind of differentiate between a meltdown and a temper tantrum is, let the child be there alone, and just kind of go somewhere else and observe the child. So if it is a tantrum, if there is nobody to attend the tantrum, the child will calm down. uh, when we talk about meltdown, when there is nobody, the meltdown will continue despite of people not being present in the environment. So that is how you can differentiate between a meltdown and a temper tantrum.
Thanks a lot, Shambhavi. I think throughout our discussion, we've been talking a lot about research and the need of research in different areas. So let's come to this point. And Dr. Zafar, I would like to ask you this thing, that research has been going out throughout the world in different areas within autism spectrum disorder, but still we are working with very limited resources in terms of, say, therapeutic intervention. So how do we fill in the gap between the two?
Yeah, am I audible to all of you?
Yes, sir.
Yeah, good afternoon to all of you. First, I would like to thank CDC who have organized this today's webinar on autism. So far as this autism is concerned, we have discussed the assessment, we have discussed the main, what is autism, what is the educational and psychological tools for assessment we are supposed to apply. But when we are talking about the research is one of the basic important, we can say the important to have any sort of information. With the help of research, you can find out the solution of the problem. With the help of research, you can find out the exact solution to these such type of problems in our society. It's basically, let me tell you one thing, when this autism has been introduced in our country, now it's just after 1995 Disability Act has been passed. After that, at that time, it was taken as one of the disability in intellectual disability. And now in the 2016 Act has been again the Rights of Children with Disabilities Act. Now the autism disability has been introduced. Now we are in a position to provide the disability certificate to these children after waiting of 15 years of children. Because when we talk about the autism, I'm very much, Dr. Thapa said that 10,000 million children are suffering from autism. The question is, who are going to assist them? Where is the manpower in our country? The important point is that we are not in a position to produce the products who can work with the society, who can work for them. Rehabilitation Council of India has started this diploma in special education because you need a special educator, you need psychologists, you need rehab psychologists, you need clinical psychologists, you need occupational therapists. So important point is that pediatrician is there, but at least once we are in a position to assist the child, you need manpower. So manpower is very less. And this is a graph like this. Manpower is here and the graph is here. The autism people are here. So we have to work, and that's why the research, we should, I feel, every education department should have a paper of autism. just subject integrated approach, so that each and every, this is just Dr. Razdan said, that awareness is very, we have to aware the each and every person. Then you can apply the early intervention. Then you can work on early intervention for these people. So you can identification, assessment, once you have manpower. Two important, I believe on three important things. First, the manpower, human resource development in the field. That is very important. Once you are in a position to produce, you have a manpower, you can work. Number two, the research. That is very important. We should write the recommendation to our HRD ministry that there should be a research project, provide funds for that, raise the funds for these research projects, and give the projects to all our researchers. We have a very good research in our country. Then the third one is first research, number two, manpower development. Then mass awareness is very important. We should aware the people. So once you will get the findings with the help of research, you can aware the public, you can aware the general masses related to that. Because people in our country, in our state, let me tell you, I would like to share my experience. In our state, people, there is a social stigma. They don't want to disclose that a girl child is having these type of symptoms. They don't want to disclose. Why? Because there is a lack of awareness. They feel that there is something wrong. Tomorrow we have to think over it. रास्ते में दाएं बाएं लोग क्या कहेंगे, मोहल्ले वाले क्या कहेंगे. It's like that. So that is why we should work together and to do something fruitful. And no doubt this webinar will be it will be 101% helpful for the society, for the community, so that we can give the exact position of autism in our country. So with the help of this research, with the help of research activities, so it is a very, very important.
Thank you so much, sir.
Ankita, yes, please.
Sir, please continue. Please continue, sir.
Yeah, yes. I said that is why the research, without research, you are supposed to give the project to the universities. We should write to the university people, education department, psychological department, even those departments who are working in the field of disability rights in our country. So give them the research, give wide publications. Research paper is supposed to be come up with the different findings. We always talk about the Western countries. Western countries has given this type or this much of, say, I'm very sorry to say that we don't have the exact figure of autism right now, because this is a totally the census, people census. We always give this duty to the people who are school teachers. Before going to census, they should be given the training how to identify and how to get the information from the families. Even families doesn't have they don't have the idea. So we have in 2011, that data is there. Now 2021 is here. We are going to again the census. At least we should give some training to those people how to identify the disability in respect to the autism in particular areas, in particular houses, particular homes we have. So this is what I'm observing and what is my personal observation.
I think Thank you. Very, very true, sir. Thank you so much. I think you've highlighted the grassroots level. We are having some problem, and until we fill in that gap of awareness and training the manpower in the correct way, it's very difficult to move ahead. And probably, as sir said this, even I did not pay a lot of attention on this note that the data that I introduced was also the numbers that is there in US. And wherever you try to search or look for it, it's very easy to find a Western number than an Indian number. It's a very, very hard thing to look for that. So thanks a lot, sir, for this discussion. From this, I think I have a question for Dr. Thapa as well, that in the latest researches, we see a lot of different intervention practices being developed, and new developments, especially in technologies, also coming up. So, anything in particular that you would like to say, talk about? Any new research intervention practices that we can implement, say, in our own country? Dr. Thapa, are you there with us?
I'm audible?
Yes, sir. Now you're audible.
There are actually there are two views. It's a purely a neurological or pediatric neurological, or it is a psychological factors are involved, psychosocial factors are involved. So many. So there are many researches which are going on, but they say the temporal lobe, because when we see these children, they are very attractive at first glance, right? We all know. But if we see closely, the problem in the ear malformation is seen in these children. Ear is deformed. Many children have ear deformities. The reason is when the temporal lobe is developing, the ear is also developing. So this is one point of research is going on, because this is a neurodevelopmental disorder, they say. This is one point of. The many other, the work is going on, neurotransmitters, and already discussed and so many things.
Yes.
But as the Kanner, who diagnosed the first time, Kanner, he said that maybe a mother, there is a defect, he's emotionally not that responsive. And he called that mother is refrigerator mother. You must be aware of this thing. Refrigerator
yes,
mother. Yeah. So maybe psychologically, and I have heard this thing, one seminar, and they say that a mother, when is carrying a child, if she's taking some medicine or she's having diabetes, even she's having diabetes, she's having some nutritional problem, or that can affect a child, and the baby can have a autistic baby she can have. Now, genetic role is there, genetic role. If the first child is male, the second child chances are very high. If the first, because the 4 to 5% male are sufferer, then female. If the first child is female, chances of next is less, 3%. The male chances are 7%, and female first is 3%. If the both childs are there, the chances become 15 to 20%. So the genetic role is there. Of course, genes are very, very important, and the research is mostly, as Dr. Razdan rightly said, that the research is going. Previously, you said there are 2 genes, 3 genes defined. Now thousands of genes are involved. So the search is mostly on the neuroscience is going on.
Right. Thank you, sir. Thank you so much for this. I think, yes, you've pointed out very correctly on a lot of latest research areas. Dr. Razdan, would you like to add something to this?
Thank you, Sanika. I think I wouldn't add, but I would say something. A lot of alternative therapies have been tried all over.
Yes.
Diet change kar lo, say gluten-free diet, casein-free milk product, but they have not been found to be of much help to these type of disorders. So many things have been tried. I think a lot of neurovitamins we used to give brain tonics, which were very popular 10 years back. But I don't think the point is, the only thing which helps this is time and proper educational and behavioral therapies. And if you have some comorbidities, you give medicines, or again try to rehabilitate them. And most important would be a good number of them can live a normal life. It's very important for us to see that they attain a reasonable level where they can do a job, because the numbers, severe cases, okay, they may not be very difficult to adjust, but majority of them should do some jobs, do some work, and get adjusted in the social milieu rather than all the time. And for that, as Dr. Zafar Saab said, it's very, very important that we come out of the shell that this is a very stigmatizing disease. This is not good. We all have to accept them. It is part of brain development rather than brain abnormality.
Yeah.
They are a little developmentally away from what we call so-called normal, and majority of them can have a good life. And we should be very careful. Many of them are very creative. We didn't mention that. Many autists have a lot of creativity in them, which could be from drawing, graphics, so many things. And this needs to be exploited and used for their benefit. And we shouldn't look only to their negative things, that they do restricted things, they do sameness. That should not be given more important. Their creativity should be given more important. So I say like this, even in ADHD, they have so much energy. I ask my parents or caregivers to convert this energy into something. Say they can learn to play football. They can learn to play a very fast game. And you see, this energy has to be converted. The way you have to convert creativity in a autistic child into something very positive, very helpful. Same way you can convert the energy of ADHD child into very positive things. I would only advise that we all accept it as neurodiversity, as I said previously, rather than a disease, and involve them in schools, colleges, universities, workplaces, and not that they have not to be helped by therapists, but they have to live normally. They cannot live a secluded, isolated life and a lonely life.
True, sir.
Thank you, Sani.
Thank you, sir. And I think I would like to add something here that since we all know that Dr. Razdan has been practicing for more than 45 years, and the positivity that we see in him and the advices that we see, I think that's the wisdom of experience. And the reason why we say that, wisdom comes with experience, we have a live example here with us today. So since there are so many doctors here with us, I would also like to ask a question. I think a few years back, I read somewhere that vaccination causes autism. And I'm not sure if it's a myth or there is some reality in this. So any doctor who would like to clarify this for us, since we are on a vaccine drive in
very important
country.
question. I think we should have touched it. I'll touch brief, but all can. There was a vaccine hypothesis, as Dr. Thapa said. There was a refrigerator hypothesis. Then there was a vaccine hypothesis that as they get these DPT vaccines, this leads to. But this has been all proved to be wrong. This was a lot of. In fact, the reason there is vaccine hesitancy all over the world is based on this autism and vaccine issues, which happened decades back. It was shown that it was not true. It was not science. It was just a wrong observation, and it was picked up by public at large. This still has effect now. Still has an effect now. I think that vaccine hypothesis or vaccine theory no longer stays. It had some traction decades back, which was on wrong premise. Anybody else could add up?
Yes, please. I think we have so many doctors with us today. Maybe Dr. Garima, you would
Dr. Garima, yes, she has.
Yes, hi, good evening. So actually, sir, it's very true. We see a lot of hesitancy with vaccination because the parents have a lot of myths around this one particular thing. Now, our textbooks very clearly mention that vaccination has got nothing to do with autism anymore. The studies have completely proven it, that there is absolutely no correlation between the two. So as far as we go, our textbooks have very clearly laid it down. But, as they say that, there's a lot of myth around this. And I think it's very important to sit and counsel the parents. because without counseling, there are a lot of myths that are perpetuated. Sometimes even the educated lot have this misinformation that vaccine is related to autism, and sometimes even other syndromes that they sort of think of. So I think it's a complete, scientifically, it's been laid out very nicely in black and white now. And I think there is absolutely no correlation. And we need to just, I think counseling is the way to go. We need to sit and counsel properly.
Now, can I make a point? One point, Sanya.
Yes, sir.
See,
Please, sir.
we vaccinate every child right from birth. And some of them will get diseases. Many children get febrile seizures. Many child get developmental delay. Many children get so many odd things. This we could say it is temporally related to vaccines, but it is not the cause. Vaccine is not the cause. See, you get do a vaccine, after a month, child may get a seizure. Yeah, it is temporally related after a month to vaccine, but this is not cause. It's very important to differentiate. Cause and temporal relations are very different. You have a bath, you get something that it may be related to bath, but it's not. Bath is not cause of your cold, as we usually say. The causality and temporal relations are entirely different. That has to be made understood. As Dr. Garima said, we have to talk, and for that even doctors have to get convinced. You will be surprised that even not educated healthcare workers have hesitance all over the world, especially who, let me not go there. A lot of healthcare workers have hesitancy because these days whole world is this time the 90% talk is about COVID vaccines. Hesitancy is all around. Hesitancy is all around. Hesitancy is all around. And if you just put a button on vaccination in COVID, you will get all the negative things, 1 to 50. Not there will be nothing positive.
Very true, sir. I think
one point I want to make. One point.
Please, sir.
मैंने एक बार पेशेंट देखा, उसकी मदर इन लॉ, मैं हिंदी में बात करूंगा, ये मिथ है कि वर्किंग कपल के जो बच्चा है उसमें जो चांसेस है ऑटिज्म के ज्यादा है. दिस इज अ मिथ. इन जम्मू की बात कर रहा हूं. आई हैव सीन ए केसेस ऑफ ऑटिज्म where the mother-in-law was telling me the history that her mother is going to office and father is also going to office. The baby is being ignored. That is why he has developed this disorder. This is another myth, particularly in this culture. Just I wanted to share this.
Great point. Great point. This is usually not talked about. This is very true. They will only tell to a doctor, phone him, kaan mein bol.
Yeah.
So very true, very true. Very true, very true, very true. In fact, we always have a reason for everything. Even we doctors, we do. And for mother-in-laws, this is the most important reason why grandchildren are not behaving properly.
Yeah.
Thanks a lot, sir, for adding to this. And I think this has been a very insightful discussion for all of us and our audience. Now, we also have with us...
One point yes. I would like to add.
Please, sir, go ahead.
Yeah, that's related to vaccination.
Yes.
We have organized the vaccination on 29th of May. I had a medical officer from surveillance medical officer WHO, Dr. Ashik. We have organized the Composer Regional Center in Srinagar. I have contacted most of the number of patients, number of the beneficiaries who are having sort of different psychological and disability. Yes, it is because of so far as vaccination. We were discussing that. There's a myth. People are not ready to have vaccine. They don't want. Even the normal people. When you talk about the disabled people, it's very difficult. I have seen one video of Dr. Razdan that he has suggested people just go for vaccination. So there is a need of, again, I can say there's a need to aware the public, especially the people who are having autism, who are having different disabilities.
Yes.
Very important. Thank you, sir.
Dr. Zafar, you got a very important point. Very, very, in fact, because we are, Sani, is very important that children with developmental delays, cognitive, This is a very important question about vaccination. When they go to, we talk at present about the adults and the adolescents, but it will come to children later on. I think it's very important to make it clear by doctors, by the healthcare workers, by doctors like Dr. Zafar, that once this vaccine is tried in children and thought to be okay, even children who have all these issues have no problems. Otherwise, you will have a lot of difficulties explaining. I appreciate Dr. Zafar. You got a very important point. It's a very important point. We all the time get telephones in the evening. Patient has seizures, 20, or can he get away? No, he's taking drugs. So you see, we have to first learn ourselves, make ourselves good, and then give a proper advice. It's a very important part, because unless we are safe in this pandemic, and vaccination is one very important mode of being safe, we should impart a proper information to all. We have every healthcare worker has a responsibility. He or she may not understand. It's very responsible to talk to their neighbors, talk to their relations, because they are trustworthy. When a thing comes from radio or thing comes from a district magistrate, it's not thought to be so trustworthy. But if a healthcare worker says, it's very trustworthy. It's very trustworthy. Thank you so much. Thank you, Dr. Zafar. You got a very important. Thank
you, sir. Thank you very much.
I appreciate this vaccination with children and adolescents and adults, because all these autistic children have become adults. You see them in adults. You see them. They don't. We don't talk about autism in adults. I think we should sometimes do it. And they all get aged, and then they have these.
Thanks a lot, sir.
Many renowned people have developed. Basically, they had autism, and Einstein and so many names are there. Sport persons and singer and actor, they had previously autism. I would say that 70% of autism, these children, they grow and work normally. So parents should not be.
Very true, doctor. Very true. There has to be a positive message about these this disorder, and they can do amazing if properly guided.
Yeah.
I think awareness is the key. So out of this discussion, one thing that we need to remember is that more and more awareness and correct awareness. So at least we cleared one important myth here, that vaccination needs to be there for everyone, and we don't need to worry about it at all. Now we have, as I was mentioning before, we have Sunena Tikku here with us. She is the CEO and founder of Brainpreneurs Child Development Center. And without her, I think this webinar would not have been possible. So thanks a lot, ma'am, for organizing this thing and taking the initiative of spreading this awareness. I want to ask you one thing that we have observed here, that today we have a team of pediatricians, neurologists, psychiatrists, psychologists, and we have counselors with us, which is very, very difficult to get on a common platform, such as this panel. So do you think certain setups like these with such collaborations can help children with autism? And what can be the possible benefits to the child in case of such collaborative setups?
Thanks, Annika. In fact, a very good question. And before I respond to it, I would really want to thank each and everyone on this panel. It's not this panel where we are trying to do some homework around it. In fact, Prajata, Shambhavi, and many of our team members, day in and day out, when we are working on our children, we keep on thinking through that what can be done better. जैसा कि बहुत सारे पैनलिस्ट ने already highlight किया है कि what are the basic things in an autistic child, what are the things that we have to look at, whether it is a social, whether it is behavior, whether it is language. तो इन सब में आपने एक चीज common देखा है, that is education and healthcare. They if there is a proper collaboration between the two, I think we can have a huge impact, in the interventions that we do. Right time pay, we will get to know that, what's the diagnosis. Once we do the interventions and early interventions, we touched upon it, we will be able to do more work around it. And finally, through these early interventions, a collaborative work between healthcare and education, I think that's a key. In fact, when I was trying to set up CDC, I did go to few hospitals, I did visit few CDCs. एक चीज जो मैंने ऑब्जर्व की कि many of the psychologists or many of the clinicians, they work from their room. But the most important thing, and one of the intents here, is this was a very insightful discussion. I think you got an answers that why we need clinicians, psychologists, psychiatrists, all of us. Why do we need to be together? You could see that. You could just see through each question that was getting answered. If we were talking about medication, we were talking about that how parent care, how much it's important that caregivers have to be, educated around it. We saw that how there are so many myths around it. So I guess this is very, very important. Maybe we are trying to do in our sphere of influence to see that what all can be done, how this inclusive setup can be done in, everywhere and across the country. So thanks again to all the panelists. I think very insightful and very informative discussions. Back to you, Sanika.
Thanks a lot, ma'am. Thanks a lot for this. We have one question from the audience here for Dr. Razdan and any other doctors, that what advice would you give to new pediatricians to pick up early and timely autism spectrum patients?
This is their, I think they will know it. It's very easy. It's very easy. Just have to observe, take a proper history. Observe. The best thing is to observe the child in home.
Right.
Or in therapy. In clinic, it may be it's very scary. Our clinics in India are scary. There are too many people around, Dr. Thapa.
Yeah,
they are already scared. Every child is scared in our clinic. I think that's not the right thing. I have found very interesting thing since this COVID thing, and we do a lot of video calls. It's very interesting to see children in their normal milieu, in their homes, and go and observe for 10, 15 minutes. You make a reasonably good diagnosis about behavior, about motor activities, about motor skills, about social smiles. You see a lot on video as compared to you would see in their. I think this is very well taught. Every pediatrician, every neurologist, every developmental neurologist, every psychiatrist will recognize autism.
Yeah.
Smell ही आती है. But question is, sometimes you may overdiagnose or underdiagnose. The point is, the best thing is to see them repeatedly at a couple of sessions, and the best thing is to see them at their natural home, which may not be, but in COVID times we have found it very easy. Dr. Thapa could add up
Right.
some more.
Right. No. I just told that
our clinics are scary.
मैंने ये बताया कि 3, 6, 9 and 12 months. If mother observe, at the age of 3 months, there should be a social smile. At the age of 6 months, the baby should sit. At the age of 9 months, he will stand with sport. And 12 months, he should start saying some words and start walking. And 1 year and a half month, मतलब 1.5 साल में, he should run. Then eye-to-eye contact is very important. Then you see, when you pick a child, so he should show you that you are picking. The posture child show, that is also important. And these children usually love, objects. They avoid, they play with the non-living things. That is also important. If a mother is showing a child with his finger something else is not seeing, this is also a sign that the child is having some problem. Sometimes, one thing I want to add, that before you diagnose that he is suffering from autism, ear check should be there. Sometimes ear deafness also become misleading. deafness, he should, eyes and deafness, the two things has to be checked. And there are some very simple eye-to-eye contact is not there. He's not giving a social smile. He's not walking. Developmental milestones are delayed. His speech is delayed. Communication is defective. Sometimes temper tantrum. Very, very easy thing, I think, the mother has to observe.
Right. Thank you
Anything?
so much. Thanks a lot, sir, for that. I think we have, very sadly, I have to say that we have almost at the end of our discussion. And I was really worried in the beginning, but now it seems like there's so much to know more and so much awareness to spread, and we have just taken the first step. So let's go ahead with the closing comments. Dr. Razdan, any closing comments you have? So you're on mute.
I will re-emphasize what Dr. Thapa says. Proper diagnosis is important. Wrong diagnosis is becomes very problematic for the doctor and the parents. That's very important. And as Dr. Thapa said, they should have a proper checkup of ears, eyes, and psychological tests. All tests have to be done. Parents have to be taken confidence, their teachers, their caregivers, and a group discussion has to be done how to go ahead rather than make a piecemeal treatment of it.
Right.
That's very important. Your developmental pediatrician, I think, and clinical psychologists can do wonders with each other. I think with the help of parents and teachers.
Right.
That would be right. That would be the team should go on for working years, rather than the parents changing their shop every few months.
Thank you, sir. Dr. Zafar, any closing comments? Dr. Zafar, any closing comments from you?
Yes, I agree that Dr. Razdan, as he said, it's a very important. It's a basically triangle. I believe on triangle: teacher, parent, and the child who is having some problem. Once these three people are working together with the help of the professional, and I believe on knock the right door at right time. Otherwise, what is happening? Our parents, our community people, they roam one doctor to another doctor. Sometimes pediatrician, sometimes physician, sometimes orthopedician, but ultimately they knock the right door. But time जो है वो चला गया होता है कभी कभार. It is better we have to aware the people at right time. So I believe what knock the right door at right time. Thank you very much.
Thank you, sir. Dr. Thapa, any closing comments?
Only one.
Yes, sir.
Early diagnosis, best treatment, best outcome. Parents should not worry. Most of the autism, these children get okay, and they can go to work, they can go to job, they can socialize, they can make relations, they can marry, they can do work. So that only one thing is early diagnosis has to be done by the parents with the help of as teachers and the surroundings all people. That's all.
Thank you, sir. Thank you so much. Dr. Garima, we'll move to you. Any closing comments from you?
Sanika, I would just give one suggestion to anybody who's working in a high volume tertiary care setup. For example, the one that I was in. What happens is that because the mothers, especially first-time mothers, because they don't know what red flags to look for, they don't come to the doctor. They will not come to you because according to them, this is nothing wrong, right? So they'll say, "अरे ये हमारा बच्चा क्या पता देर से grow कर रहा हो, देर से milestones आ रहे हो." So I think the red flags are never really laid out for them in a way that they can approach help when they can. So I think for a pediatrician, like that question was, for a pediatrician, what you can do in these tertiary care high volume setups is that हम 24 hours तक तो हर baby admitted रहता है, fine. Before discharge, we only sign off their discharges. Let us at least collect the mothers and counsel them that there are certain red flags जो आप देखते रहो. I think if you're able to communicate that before discharge, all first-time mothers and everybody else, they can keep an eye out for these red flags, because as you say, early intervention is everything. So most of the people that we deal with are are coming from a lower socioeconomic strata, and unless there is a real problem, they will not come and see a doctor. So I think just laying out that 3, 6, 9, 12 thing that Dr. Thapa told us, I think just laying it down, counseling before the baby is discharged with the mother could really go a long way. I think that is all I really need to
Thank
say.
you so much. That's a very simple and very informative way, I think, to deal with such a situation. Spreading more awareness and correct information is very important. So, Aprajita, we'd move to you. Any closing comments from you?
Sanika, one thing, am I audible, Sanika?
Yes, Aprajita.
Yeah, so one thing that I would like to add is to keep a check on the screen time of the children as well. So if the child is, say, 6 months or 9 months, and even at 9 months, parents start introducing phone because they are occupied. Maybe the father is working, the mother is occupied. So what they do is they handle the phone, which can worsen the severity level. And also, if the child is just non-autistic, it can show some autistic features in the child. So I think one thing that I just want to add and highlight is that, while counseling, it is also important to tell and inform people to keep a check on the screen time of the child.
True. I think, in fact, screen time is something that should be regulated in children overall. And as good it is in terms of information, there are a lot of negative effects also which are associated to screen times. Shambhavi, what would you like to add here?
So I think we should work on normalizing neurodiversity. So as we were talking earlier also, as mental health should be a part of school curriculum, children at school should be taught about what is autism, and they should try to make children who suffer from autism comfortable at school. So it could be made through small comic strips, like how a child with autism might react. So the normal child or normal child would understand what is neurodiversity and would empathize with the child and help the child to overcome social anxiety or bullying at school. So I think that is also important to spread awareness at school levels also.
Very true. Thanks a lot, Shambhavi. Sunena ma'am, coming to you now.
I think all we have to say is that we are all together in this game, and this should not be the end. I think this is just a beginning, and I got a lot of ideas, while the panelists were talking, that how we can further build on this awareness. So all we need to ensure is we provide a safe environment to our children, and of course we need to take lots of care about their mental and emotional well-being. On the neurodiversity, that's again very close to my heart, and we have already started doing some work on pre-vocation and vocation. So I think more emphasis on that should also be given. So above all, once again, thanks to each panelist for giving your time. And I think it has been great help and very encouraging session that I have heard. And I would also like to, just highlight Mr. Lokesh and Mr. Rohit. I know they have always, Pallavi, they've all been working.
Thank you, Lokesh bhai. Thank you very much for being so good and wonderful in helping us this.
We got, yeah.
Thank you so much. Thank you, sir. Thank you, Azai.
Yeah, Sanika, back to you.
Thanks a lot, ma'am. I think I would agree to you. This has been a very insightful session, and I think takeaway points would be spreading more and more awareness, passing correct information, and early intervention. These are the most important things. So look out for children and be more acceptable. I think we need to start spreading awareness. This was our initiative to at least take a few steps ahead in passing correct information to people, whoever needs to listen to this. So you don't have to worry. We are all here with you together in this journey. And that's all, I think, for now. So thanks a lot for joining us, to panelists and our audience.
Thank you, everyone.